Good morning, Chairman and Co-Chairman, and all the participants. I would like to thank the TOTS for an opportunity for me to be standing here and give a talk about the fragility pelvic fracture diagnosis and treatment plan. So agenda today will be the definition, the diagnosis and the treatment plan, including the fracture treatment and the osteoporosis treatment. So what is the fragility fracture of the pelvis or the FFP? It could be the fragile bone, which have significantly reduced bone stock from osteoporotic fractures, or maybe some insufficiency fracture such as irradiation, long-term immobilization, or bone graft harvesting. So the presentation of the FFP is mostly from frail elderly women compared to high energy in young male, and they can come with the acute from low energy fall or maybe insidious onset without any history of trauma. Most of the time, it would be the bony structure disruption without ligamentous disruption, and also commonly is isolated injury. So the clinical presentation would come with the back pain and the groin pain, and from physical examination, you can see sometimes they have pelvic compression pain, sacral tenderness, or pubic rami tenderness. So if they come like this, so you should send for AP pelvis film and also for the LS spine film. So take a closer look at the film. We can see that in this patient there is a displaced fracture of the superior and inferior pubic rami on the left-hand side, and inlet and outlet film also show the same thing. We cannot see clearly what happened on the posterior pelvic ring. So usually in this case you would need to do the CT of the pelvis, thin cut, usually less than 2 millimeter cut per cut. And you can see from the slide that in this patient they have impact fracture of the sacral ala on the left-hand side. And also when you perform the CT scan of the pelvis, you do not forget the sagittal cut of the sacral body, because you may find something like this, which indicate the transverse fracture of the sacral body. So in patient that CT scan do not give any more information, but patient have a very severe clinical, so maybe we should opt for the MRI pelvis to find the occult fracture, which can be seen on the left-hand side is the T1, that you can see the bone bruise, and also you can see the fracture line on the T2. So Raman proposed the classification for the FFP in 2013. So they consist of 4 classifications. The FFP type 1 is the isolated anterior pelvic ring fractures. The type 2 is the isolated non-displaced posterior and anterior pelvic ring fracture on the one side. And the type 3 is displaced fracture of the posterior pelvic ring on one side. And for the type 4 is bilateral displaced posterior ring fractures. So they classify the type 1 and type 2 as the stable type, and then type 3 and type 4 as the unstable type. So for type 1, usually you can see that there is unilateral fractures most of the time, around 20%. And for the type 2, usually it is impact fracture of the posterior ring, or maybe a complete fracture, which consists of 50% of all the cases of FFP. For type 3, the most common one is the posterior ring is the iliac ring fractures. So this fracture, you can see that there is no iliac ring fracture in the type 2, because most of the time this kind of fracture will be unstable because there are no ligamentous attachment to the iliac ring fragment. And for the type 4, the most common one is the H type or the U type sacral fracture, which have the transverse fracture of the sacrum that you usually see on the sagittal view of the CT scan. So don't forget to look for the sagittal view. So for the goal of treatment in this patient, so what we want is that for them to go back to walk, and we want them to go back to walk fast. So also we want them to be pain-free, and also don't forget to treat the osteoporosis fracture, osteoporosis. So what do they recommend? The Raman recommendation is that the FFP type 1, you can go for conservative treatment most of the time. And the controversy is at the FFP type 2, which you can start with conservative treatment first, but there are no defined length of time how long should you be conservative in this patient? And if the conservative treatment fail, you can perform the percutaneous fixation of both anterior and posterior pelvic ring. For the FFP type 3 and type 4, usually they recommend that you perform operative fixation on this patient as they are considered as unstable. So let's look at the evidence. The conservative treatment for all the fracture type, mostly in Japan, they report that most of the case, they can be conservative. And usually the criteria for the failure of conservative treatment is that they would define a specific length of time. And if the patient cannot sit by themselves or stand by themselves during the 7 to 10 day period, then they would consider that the failure of conservative treatment. So as you can see, in their theory, only 5 to 10% need operative treatment after 7 to 10 days. But we can see that only less than 40% of the patient regain pre-injury standing and walking ability at 1 year. So these fractures are have very poor clinical outcomes. So specifically for the FFP type 1, Romans report in 2020 that in 138 patients, the 1 year mortality rate is about 3 times of the normal population, and the utility score of the EQ5D is decreased around 0.15 point. And only they show that only half of those patients were treated with anti-resorptive treatment. So this shows that patients with FFP were often overlooked for their osteoporotic disease. So we should also always consider osteoporotic treatment in this patient. To compare the conservative treatment of the FFP type 2 to type 4 to conservative treatment, we found that in the patient with the propensity match study, the operative treatment have higher 2-year mortality, but after 2 years, patients who were operated on have lower mortality after 2 years. And comparable functional outcome at the last follow-up. The recent study showed that patients who were operated on have more complications such as the UTI and bed sore, which can maybe because the patient who were decided to be operated on have more severe clinical presentation. But they found that patients who were conservative, who were treated conservatively, have higher 5-year mortality than patients who were operated on, around 20%. And also, specifically in the 2B fractures, patients who were treated with operative treatment, they regain better mobility after operative treatment. So what can we gain from all of this? So the general consensus of the treatment paradigm is that in patients with mechanical instability, such as the type 3 and type 4 of FFP, or patients with severe pain, we can go ahead and do minimal invasive surgery if possible. And also the emphasis is on the complete ring fixation, so both anterior and posterior ring fixation. But if there is no gross mechanical instability, you can admit and then do pain control and then re-evaluate them on the defined time period. And if there's still some pain or they cannot mobilize, then you go ahead and do fixation. But if it is acceptable, then you can discharge and then follow up as an outpatient. Also follow up for the displacement of the fractures. If it becomes displaced or patient have increased pain, then you can decide to do minimal invasive surgery. So one is the option of the operative treatment. The anterior ring fixation, you can do either external fixation or some patient may choose the internal infix. But what I prefer is the retrograde transpubic screw and also the plate fixation. For the posterior ring fixation, usually we can do the minimal invasive SI screw or the TITS screw, the transsacral bar, but we do not have it in Thailand, and the posterior plate or LCP, or maybe do the lumbopelvic fixation for the highly unstable fracture types such as the type 4 H-type sacral fracture. So the consideration is that for each technique, if you perform the SI or TITS screw, at least 2 SI screws should be performed. But if you choose the TITS screw, you can do 1 or 2 screws. Some study also report the use of cement augmentation, but I do not have any experience with them. So also for the retrograde rami screw, they should be bicortical purchase and fully threaded with the transpelvic insertion point. And for the plate fixation, some study say that you should consider double plating for higher stability. For other techniques, we should consider MIS technique if possible, such as the minimal invasive fluoroscopic or the navigator guide lumbopelvic fixation. So this case, this patient, 89 male, fall with the FFP. At first, he was type 1 patient, and he refused to admit and for the pain control. After 2 weeks, he came back, and he can still not sit upright on the bed. So we sent for the CT scan and found that the posterior ring also have some fractures. So we perform a percutaneous fixation, and the patient can sit upright immediately post-operative, and on the day 1, he can walk with walker without any assistance. In this case, 95-year-old female fall with the FFP4B. We can see that the displaced anterior and posterior ring fixation. But in this case, very old, so we decide, the pitfall is that we decide to do only posterior ring fixation. She can walk without pain, but after 4 weeks, the screw loosening. But from CT scan, we can see that the fracture is healing, and she can walk without pain, so we do not perform anything more. We can see that in some study, we found that if you do the retrograde rami screw with the lateral to the pelvic body insertion point, some screw can come out like this, or maybe like this. The screw will come out if the insertion is not medial enough. Also, we should do the bicortical transpelvic rami screw purchase. So if you can see here is the screw should penetrate the lateral cortex. And also the plating, the single plating can become fracture, can fail like this. So you can consider double plating for increased stability. So for the osteoporosis treatment, the TOPF guideline classify this as the high-risk fractures. So we can only start with bisphosphonate treatment, but parathyroid hormone can be used for off-label use to enhance healing. So in this case, this is a case with 60 female, insidious onset. After we operative fixation, we only use the single anterior plating, and at 3 months, the screw loose. So we start with the PTH treatment, and after 1 year, our fracture is healed, and she can walk properly. So parathyroid hormone, the evidence is not clear, but it can be benefit in the delayed union case. All right. So the takeaway is that in the FFP, CT scan is the standard modality for diagnosis. So initial conservative treatment, there is no defined length, so you can choose for yourself. But what we want is that we want them to walk and fast. So operative treatment may benefit long-term outcome, but you need to be minimal invasive and maximum stability. And also don't forget the OP treatment. Thank you.